Hello, friends and colleagues. Today, I will be sharing my notes about primary biliary cholangitis. So, one of the autoimmune condition, which is again common in females. So, let's just start revising it, which was formerly called as primary biliary cirrhosis. It is the most common cholestatic disease, and it is called as mist disease. Now, this is because it has certain um, symptoms like fatigue and pruritus. So it would be starting with all these very unnatural and very vague symptoms. So that's why this is a mist disease. Now again, this is an autoimmune origin, so that's why it will be more common in females. It is 9:1 in females. That is the ratio, and mostly in a 40 to 50 years of the age group. If the males are affected, now it is a severe disease and it has a poor prognosis. Okay, just like SLE also, when the males are affected, it is a poor disease. So in females, if it is a younger age group, then again it is a poor prognosis. So obviously it is an autoimmune origin, so there will be certain family history. So genetic susceptibility with the environmental factors. So this will contribute to the disease pathology. So now when we talk about the antibodies, so it is the anti-mitochondrial antibody that you have to keep in mind. And now what happens is there are certain cholangiocytes. Okay, so these are actually antigen presenting cells. Okay, now whatever there is a destruction of the bile cells, so that will lead to ductopenia in this disease, and this is causing a bile acid accumulation. So there is this B and T cell infiltration, because of which there would be a destruction of the bile cells. Now clinical features. It is actually a middle-aged, then there would be fatigue, which is a vague symptom, which is then there would be actually a pruritus, which is actually seen in an early disease, and jaundice would be the next symptom. Again, after the jaundice, we could see a portal hypertension and cirrhosis. Now, this is something which is a irreversible disease. Now, this pruritus is actually at night, which is disrupting the sleep. Okay, so this can give us a clue. There would be xanthosma, that is a lipid deposition. Now, there is a bile acid, bile cells destruction. So, yes, there would be bile acid accumulation. Okay, and also there would be a xanthosma, lipid deposition, hyperpigmentation. Then there would be deposition of the bile acids in the intestine that will lead to the fat soluble vitamins, that is A, D, E, K deficiency. Along with that, there will be osteoporosis as well. Then we're coming to the hyperlipidemia. So this is actually certain points we have to remember about this. If it is an early disease, there is high HDL and low LDL. But if it is a late disease, there will be low HDL and high LDL. Okay. And so of course we want HDL should be high and low LDL. And then as the disease progresses, it becomes worse. Now, of course, it is associated with other autoimmune diseases like Sjogren's, rheumatoid arthritis, Press syndrome, Raynaud's. Okay, and the most common association is the Sjogren's with distal RTA. Okay, so there are certain phases. There is a silent phase, which is actually where the LFT would be normal, and only the antibodies, that is we're going to see about that, anti-mitochondrial antibodies would be positive. Then asymptomatic phase, the LFTs will be abnormal, but the symptoms are not there. Then symptomatic symptoms will be there and LFT would be abnormal. And in the liver failure, CLD, that is the portal hypertension, will be there. So now this is actually a concerning disease because there is a chance that the patient can go into hepatocellular carcinoma, and that's why it becomes very important for us to prescribe him ursodeoxycholic acid, okay, for at least 1 year. Okay, because it has shown that with the help of ursodeoxycholic acid, the chances of the primary biliary cirrhosis proceeding into a hepatocellular carcinoma has been very good response. Okay, so now if say I have given a patient ursodeoxycholic acid and for 1 year and there is no response, then we can say there is a high chance of hepatocellular carcinoma. So on the clinical examination, what should I say? There should be hepatomegaly, there should be jaundice, there would be hyperpigmentation, there should be xanthosma, there should be splenomegaly, and there should be signs of portal hypertension, including that of the ascites and splenomegaly, and then caput medusa, and we have the GI bleed, etc. All of the complications. Now, diagnosis. Diagnosis, I have anti-mitochondrial antibodies. That is very much important for the diagnosis to occur. It should be more than 1:40, more than equal to 1:40. On the sonography, I should be seeing a biliary obstruction because there is a destruction of the bile cells. And then there would be ALP levels, alkaline phosphatase levels should be raised. That should be 2 times raised. On the biopsy, there would be ductopenia. Okay. So now there are certain differentials you have to keep in mind. Okay. So what are the differentials to this disease? Now we have seen about the symptoms also. So it can mimic like that extrahepatic biliary tract obstruction. We can think of strictures. We can think of malignancy. We can think of a primary sclerosing cholangitis, drug-induced cholestasis, autoimmune hepatitis, alcoholic hepatitis, sarcoid cirrhosis, and TB. So there would be increase in the IgM levels. Okay, and actually the mitochondrial antibodies, these are actually IgG types. Okay, INR will be raised, bilirubin will be raised. ANA should be positive in patients with the AMA negative patients. So this can be a thing in a patient that AMA is actually negative, but that same patient can have ANA positive. Okay, so this can happen. So whenever this is there, we have to see other antibodies as well. Now we coming to anti-centromere antibodies, which is associated with portal hypertension. This is a very important part for MCQ. Then anti-GP210, that is actually having a high specificity and sensitivity. Then we have anti-SP100, which has high sensitivity and specificity. Okay, so these are the poor prognosis indicator. Okay. Then on the imaging, you should be seeing obviously there should be a lymphadenopathy, and we do an MRCP because we have to rule out primary sclerosing cholangitis. We have kept one of the differential, so we have to rule out that also, and there will be a mild atrophy. Now we coming to the staging. We have a Ludwig and Schaeffer staging. So there is a stage 1 which is called as there will be a portal tract inflammation, which is actually a non-separative destruction of the bile duct. So there would be a florid duct lesion. This is very, very important. It has come multiple times. So there is a florid duct lesion. It is a non-necrotizing epithelioid granuloma, which would be seen over there. Then we have a stage 2, which is having inflammation at the interface. And stage 3, there will be actually a septal fibrosis. And then we have ultimate cirrhosis stage. So prognosis, of course, depends upon ALP levels, anti-centromere, anti-GP210, bilirubin, PTINR, platelets, albumin levels. Now coming to the treatment part. So first of all, we have already seen ursodeoxycholic acid that has to be prescribed to the patient as it reverses the disease, okay, early disease. So it improves the histology, it improves the labs also, and the disease, and one of the complication, that is a bone disease, osteoporosis. It will not improve. Okay. Okay, so it has certain actions on the hepatocyte, on the cholangiocytes, and on the ileocytes also. So hepatocyte, it stimulates the biliary secretion. Okay, it inhibits the apoptosis. It activates the glucocorticoid receptors. It reverses the aberrant expression of the HLA class 1 molecules. In the cholangiocytes, it protects against the cytotoxicity of the hydrophobic bile acids and anti-apoptic effect. On the ileocytes, it inhibits the bile acid carrier. So the second thing is obeticholic acid. Now this is also very important. It has come as an MCQ. If the ursodeoxycholic acid is not there, what is the other alternative that can be used? So in case of the non-responsive to ursodeoxycholic acid, we can use this. This is actually a FXR agonist. It has anti-inflammatory action and anti-fibrotic action as well. And the next thing is fibrates. Now, this is also as an anti-inflammatory, anti-fibrotic, not very much recommended, but yes, we can use. Now, another thing is rituximab. We can give a trial of rituximab. Budesonide, transplantation, of course, in case of CLD patients. We have to manage portal hypertension. Terlipressin has to be given to such patient. Midodrine can be also given to such patient, like that. Address the osteoporosis, calcium, and manage the Sjogren syndrome. Okay, so for what about the complications? Complications like osteoporosis, osteopenia, severe bone disease, we have to go with calcium, that is 1200 to 1500 milligram per day. Vitamin D levels, that is 600 to 800 international units per day, and alendronate, that has to be given for the osteoporosis. Then vitamin D 25,000 to 550,000 international units per week we can give. Vitamin A can be supplemented. Vitamin K, that is 5 milligram per day, can be also given. For the pruritus, now this is very important because not always we can give cetirizine. Okay, so we have other alternatives also. So this is very important. Hydroxyzine 25 TDS milligram. Then cholestyramine, that is to be given 3 to 4 gram 30 minutes before the meal. Rifampicin, that is 150 to 300 milligram. Remember, this dose is very different from the usual one. Okay, and naltrexone 50 milligram daily. So these are the 4 drugs that can be given for the pruritus. That is the recommended 4 drugs. Then liver transplantation if there is a disabling fatigue, if there is intractable pruritus, if there is severe sarcopenia, and if there is a portal hypertension, CLD. Okay, so remember, anti-mitochondrial antibody can be positive even after transplantation. Okay, so this is very important. And one of the MCQ has been asked that early change in the biopsy, there is a loss of canals of Herring's. Okay, so you can have to keep this in mind. Okay, so I hope you have enjoyed this video. Thank you for watching.